am really charged up about today's discussion. Every month, we're going to be meeting aging life care managers and having just this open roundtable discussion format leading up to the Mid-Atlantic Conference that is going to be held on November 3rd and 4th in Bethesda, Maryland. And so uh and I see that I've got our panel members are all here. And before we meet our aging life care managers, we have a special treat because one of the sponsors of the Mid-Atlantic Conference is here today. And I want to make sure to introduce her and also give her the opportunity to tell us a little about the Fitzgeralds of the Palisades, which is the organization that she's representing. So, Tiffany, great to have you today. Thanks for sponsoring the conference. And I've got a slide deck for you that we can walk through so that people can get to know the Fitzgerald a little bit better.
Thank you. Good morning, everyone. Glad to be here, or good afternoon, I should say.
Okay, let me pull up your slides here and feel free to jump in and just tell me when you want to advance it.
Sure. So, obviously, hi, I'm Tiffany with the Fitzgerald. I am so excited to be on today. We are located in the Palisades neighborhood of DC. A lot of people ask, where are you? We are right beside Black Salt. We are right where the old Safeway was, so a well known location. We are going to be 6 floors, and we're going to have a pool, we're going to have a pet spa, and lots of other great things. So, can you go ahead and thank you? One of the cool things about us, we are a signature community for Kisco. And what that means is we really have an elevated approach of how we handle our residents and members. We really focus on anticipating their needs and the hospitality piece. So it's like resort living every single day. We have a phenomenal activities department called the Art of Living Well, and really focuses on the 9 dimensions of wellness, spirituality, health, and all sorts of things. So we have some exciting stuff planned. You can go ahead and go to the next slide. Just to tell you a little bit about Kisco Confidence and what that means. It means 5-star lifestyle. So we are actually the only senior living communities amongst the brand that are Forbes 5-star travel guide standards that we use. So just really unique with that. In addition to, we have just exceptional standards that we are going to be exceeding every day. We also look at trust and transparency. So just being really transparent. For instance, we don't open till January. At one point, that was going to be a little bit sooner, but just having that consistent conversations with our people that have deposited or who are interested in us. And then preparation and protection, just really best in class to keep everyone safe. So following the CDC guidelines, having AccuShield in house for people to sign in and out, and actually making them update that. We also have the health and well-being, enriching the dimensions of wellness. So kind of like I said, our Art of Living Well program will really be just over the top, doing some really great exclusive opportunities, but also just more person centered. What do you like to do? So one thing I've been doing in my role is actually meeting with each of our depositors one-on-one, or in some cases couples 2-on-1, and learning about, what do you like to do? What do you want to do? This is your community. You're truly the culture keepers. How can we help display that every day? And then, of course, Kisco follows up, focuses on recruitment and retention as well. So just really hiring that top talent. And you can go ahead and go to the next slide. Part of my role is not only amazing healthcare partnerships, but it's also some premium partnerships. So things like the Kennedy Center, the Spy Museum, and seeing what exclusive behind the scenes can we get. And so that is what I've been working on, in addition to some local artisans. So there's a company called Fig and Fire. They've created a beautiful scent for us that smells so good. It's called the Fitz Spritz. Um, and then, of course, we're partnered with Black Salt. So we host a lot of events there. We actually have full setup in the back room to have a TV, to do virtual tours and that sort of thing. And then, of course, we have Black Coffee. They have come up with a roast just for our community that will be served. And I see the questions coming in. So I will say we are Northwest in the Palisades area. We are slated to open and take our first members, residents moving in January of 2025. We are hoping in August to be able to invite you all in for some mock apartment tours and to learn more about the community right there at the actual site in that area itself. So I'll make sure you all get information. Are there any other questions?
Um, yeah, this is great. And I'm dropping the website in there. And what I'd recommend is folks just and Tiffany, drop your contact information in. And I know you're going to be hanging behind the curtains there. So folks, if you've got additional questions for Tiffany, feel free to drop them in there and she can respond to those directly. Well, and actually here, let me quickly, before we jump in and meet our care managers, I just want to once again thank thank the Fitzgerald, but also let y'all know that the what we're doing these discussions leading up to the Mid-Atlantic Aging Life Care Conference, which is going to be on November 3rd at the Bethesda Marriott, and the Fitzgerald, Kensington Senior Living, Beverly, Inspire are all sponsors that have committed to supporting this event, and we're thrilled to give them a shout out and a venue to sort of share their wonderful resources that they have. So thank you so much, Tiffany. And we now let's jump in and meet our aging life care managers. So how about we do this? How about we go around the little Brady Bunch thing here and get to know each of you first, and then we'll talk about what is an aging life care manager. And then I think each of you has some real life stories that you like to share. And then hopefully we can get lots of community feedback and make this an engaging dialogue. Let me start with you, Rebecca. Tell us a little bit about your background and what led you to become an aging life care manager.
Sure. Thanks for having us, Steve. My name is Rebecca Roskey-Brunner. I am with Complete Care Strategies. We are located outside of Philadelphia in King of Prussia, PA. I was an emergency room nurse for 20 years. And during that time, I saw a lot of different clients come in, or a lot of different patients at that time come into the ER, and they had no family. They were coming in from, nursing homes. No one would be there with them, or their family lived across the country. And I would call the different communities and try to find out information about the patient, and they were like, oh, we don't have any information on them, or I just started my shift today. So I really wanted to be an advocate for people and be their person if they needed someone when they were in distress. So that's how I got into
I
the
love
aging
it.
business.
I love hearing these stories. And Allyson, what brought you into this profession?
Okay, my name's Allyson Stanton. My company's Stanton Aging Solutions. I've been a healthcare social worker for 28 years in hospitals, skilled nursing facilities, and CCRCs, continuing care retirement communities. My entire career has been focused to the older adult population and their families. I think I'm going on 28 or 30 years, boots on the ground. And even prior to that, I was a home health aide in New Jersey in college. So I just had a calling for this. My passion being in healthcare for this long now is really getting people to focus on advanced care planning and ensuring that they have a voice.
I love it. And Christine, and I like the banner back there. It's sort of like you're with an organization that's been around 100 years. This is amazing. But before we dive into that, tell us what brought you to this profession.
Yeah, so my name is Christine Bitzer. I work with Seabury Care Management, which is a program of Seabury Resources for Aging. Um, I also got into older adults early on in my social work career. I'm a licensed clinical social worker. I actually fell into care management as part of my internship, which is unique and interesting for this area. But from there, I just fell in love. I worked with home care agency, and when at that time, Seabury Care Management was ESM Cares, when they had an opening, I jumped for it. And what I liked about care management, which was different from anything else, any other part of healthcare that I had been in, was they really looked at the whole person. Not just concentrating on the medical and the healthcare, which of course is a lot of our backgrounds, but also what about the social isolation? What about loneliness? What about connecting to other resources? So that's what brought me into this.
I love it. All right. Now, before we dive into some sort of real life stories, Rebecca, would you like to take a stab at sort of what is an aging life care manager, especially for those that may be tuning in and they're like, okay, I'm going to tune in. I don't know what the heck this profession is, but let's kick this off with what is a care manager, and then we can explore some different real life stories.
Sure. So an aging life care manager, also known as a geriatric care manager or a care manager or a patient advocate, is a nurse, social worker, occupational therapist, somebody who has been in the social services field. And we look at a holistic client-centered approach to taking care of clients. So we sometimes think of ourselves as a professional family member. We work with families and aging adults or those with special needs to make sure that they have the best quality of life for the rest of their lives. We advocate for them in the hospitals. We advocate for them at home. We're kind of like their person. If they need something, we are there. We help solve problems, and we are their person. I don't. It's really taking care of the whole person and looking at it from multiple different angles.
Well, I've heard over the years people referring to aging life care managers as wedding planners for growing older, or the quarterback that helps, an individual or family make plans and be appropriate. And folks, I dropped into chat a link to the national chapter website and just a definition of aging life care from that website, if that's helpful with you. Okay, well, what I love is hearing real life stories. And just folks, just big asterisk next to this is that these no names are being revealed. We're being very vague when we're sharing the real life stories, but it's so much better to sort of hear these real life stories because we might relate to them, and as opposed to a definition of, well, we do X, Y, and Z. So each of the care managers has sort of a real life scenario that they're going to be sharing with us, but we'd love for y'all to jump in, and also, even if you've got a question or a current issue that you're working with someone in your life, feel free to jump in. I mean, this is this great opportunity to have the feedback of 3 different aging life care managers in one room. It can really lead to a wonderful discussion. So here, Rebecca, since you still have the mic, kick us off with one of your real life stories, and then we'll do Allyson and Christine.
Sure. So we had a client, we're going to call her Alice, and she was a proactive planner. She was in her 70s. She had never been married, no children, no real family to speak of. And her best friend, who was her healthcare power of attorney at the time, had just passed. So she was really looking for someone to be her advocate. She didn't need us. We would check in on her and she would call us if she had any changes in medicine, but she really didn't need anything. At one point, there was a ice storm and a tree fell on her street and her car was blocked. The power company said she wouldn't be able to get her car out or get her power back on for 7 days, and it was very cold. She didn't know how to call an Uber, so she called me. I called her an Uber. She got to her friend's house. After a couple of years, she needed a little bit more help and we jumped in and did everything we need. And then one day she called me and said, I don't feel really well. I feel like I'm dying. So I said, all right, I'm calling 911. I called 911 and we got her to the hospital. She had always lived a very quiet life. And when she got to the hospital, she was jumping out of her skin. And at that point, I kind of realized that she was probably neurodivergent and maybe had some sensory processing disorder. So we worked with the physicians and everyone to get her into a quiet area, shut off the alarms in her room, and make sure that she was comfortable. We realized pretty quickly that her disease process was pretty severe and she was going to be hospitalized for a while. So we jumped right in and made sure that her cat was fed. We called her financial power of attorney to make sure that all of her bills were paid and nothing was amiss. When she was ready for discharge, we made sure that we got her into a exceptional rehab and that they were aware of her sensory processing disorder, because I'm not even sure that she was aware of it because she listened to classical music and always was at home and just really led a really quiet life. But it really came into view when she was in the hospital. So we tried to ensure that her whole person was taken care of.
Man, well, I love hearing that story because our number one discussion topic on this platform is solo aging. And that really represents a typical sort of concern that solo agers or people that identify themselves as solo agers bring up from time to time is that you sort of wake up one morning and all of a sudden you've either outlived all of your loved ones or you just don't have the community around you that you once had. And it's a great illustration of how somebody can make a relationship with an aging life care manager, and then in the future, they can utilize them. Great story. Now, before we jump to Allison, let me address Kristen has a question, and it is, how do you differ from healthcare advocates? Do you handle all aspects of healthcare? All three of you can jump in on this, but I actually felt like Rebecca's scenario there gave an example of what patient advocates do as well. There is an intersection between the professions.
Yes, I mean, we advocate for all of our clients in healthcare. I have social workers, nurses, and occupational therapists who work for me. So we are very well versed in all the different aspects of advocacy in the medical realm, and I'm sure everyone else on this panel is also.
Great. And then before we Allison, I promise we're going to get to your story, but got a few more questions. First, we've got somebody that says, can each of you just again state the regions that your organizations cover?
Sure, I guess I'll go first. We are in Pennsylvania. We also cover South Jersey and Northern Delaware. So I would say Pennsylvania from Philadelphia, all the counties, all the way out through Lancaster, and then up to Bethlehem.
Okay. Allyson Stanton. Oh, sorry. I was trying to keep the order that Steve put us in. I listened, you guys. All right. So I'm based in Howard County and we cover Central Maryland.
Okay. And then Christine?
Yeah, we're based in the district, so we cover all of DC, but then we also cover Montgomery County, Prince George's County. We go into Northern Virginia and a little bit in Howard and Anne Arundel.
And then I just want to reiterate, because we we have people from all over the country that tune into these discussions. But if you go to the Aging Life Care website, aginglifecare.org, you click on this orange button that says Find an Aging Life Care Expert. They have this amazing search tool that you can use. You can type in your zip code and, a distance, and find a care manager that way. It pulls up a nice little listing there. Okay. I promise we'll get back to the other questions that are coming in, but let's hear Allison's case study.
Sure, and I love the questions, so keep them coming. So one stat I'd like to start with is that 70% of Americans want to die at home. And guess how many are not? 70%. They are dying in hospitals and other facilities. I think the reason for this is because people aren't having necessary conversations with ourselves as well as with our loved ones. So a case snippet that we see all the time, I have many I could talk about, but is when we are called in for crisis management because no pre-planning was done. A case we had, it was an elderly gentleman that lived alone in an apartment building, and he had advanced stage neurocognitive impairment. He was a smoker. He was burning holes in furniture. His stove was filled with papers and food, as well as the oven filled with stuff, and it was still turned on. Moldy food in the fridge that we had to obviously get rid of. We saw maggots in things. Medications were dropped throughout the apartment. Obviously, there was a lot of medication mismanagement, as well as no physician or appropriate medical care. Major safety as well as isolation issues. He had one family member, but they were not a POA, a healthcare power of attorney, or a financial power of attorney. But luckily, they did want to be involved. It wasn't a child, it was a cousin, and they were fairly local. His insight was so impaired, as we know, which happens with advanced stages of dementia and such. So we had to get attorneys, and sadly, we had to file for guardianship, and we went to court, and he was in the hospital and opposing, obviously, during the court, but he was so impaired. But the judge, we tried to give him a voice. But anyway, he was deemed incapable of making informed decisions. An attorney was appointed for financial and personal advocacy. We were able to budget plan, clean out the apartment, and move him in an appropriate, safe, small residential assisted living that he can afford to live to 100, so he'll never have to leave again. But I think the moral of the story is that we all have goals about aging. It's not about dying. It's how do we want to age when things change. And you will not reach that goal if you don't talk. So just talk and start planning, please.
Man, well, that's another great study case where, you're dealing with crisis, you're dealing with memory impairment, coordinating with other service providers, and holy cow, and so many of us that are thrown into caregiving roles, it's like, because we've never done this before, it's like a foreign language. And you all have been speaking this language for many years, so you're able to present options much quicker than those of us who are new to this. I love that scenario there. And let me look real quick here. Well, I'll tell you what, I know there's more questions, but let's jump to Christine, and then we can just have an open dialogue on all things aging and aging life care. Christine, share with us your story.
Okay, thank you. First, I want to back up just a moment because unlike Allyson and Rebecca, Seabury is a nonprofit care management group. And that's unique. There's about 3 or 4 in this area of the DMV. I see there's a couple of other members who are listening who are from Iona, which is another one. For us, what we try to do is to fundraise for what we call an equity fund, which then allows us, as people spend down, to be placed onto a sliding fee scale. Again, based on availability, et cetera, at different rates. But that is one thing that's very important to us and to our care managers. And I should say that all care managers try to do something to give back to the community. It's just, we are a nonprofit, so that's one of our mission statements. So the person or the people that I want to discuss, it's a couple who are on our subsidy. They actually spent down to the point where we added them into our subsidy. So they came to us as a full fee client. We like to have about 20% of our service hours subsidized. She had some mental health issues that she was managing well, but a lot of it was due to his management, and he was now dying. The home was starting to get a little bit chaotic. They were living in a single family home. So when the care manager was brought in by the power of attorney, who they had no children, this is an out-of-state family member, we needed to get some supports in there for him, make sure that we were providing some therapeutic care for her, because this was really tough for her. This was her lifelong partner. They had been married for a very long time. And I know one of the questions was how long. This individual has been with us now for 11 years, which I would say in recent times that's become less typical, but we still, as you can see, have people on our caseloads that have been with us for a decent amount of time. We did help them to clean up, and then we connected them with downsizers. We helped them move into a smaller community. We did help connect them with hospice, and then helped her through that grieving process along with hospice. It turned out as well, of course, that she hadn't been really following up on her medical care. And we learned, much like Rebecca had said, it was easier for her to have a visiting doctor. So we connected her with a visiting doctor who could come into the home. The care manager is very active in helping take her to any of her specialists, help make sure that her medication is managed well. Again, we don't handle medication because we're social workers, but it's connecting with the individuals who can do that. At this point in time, she really needs a lot more care. And so we've moved her into another community. It's not ideal, but given what her financial circumstance was, that's another thing that the care manager does, is they help to anticipate what's coming down the line and connect with what are the community benefits. So it's not just about what can you pay for, because we're blessed in this area that the 3 of us come from. There's a plethora of services and providers who are out there. But it's also about, okay, what are the benefits that you qualify for? And let's look at that first. So it's been a really nice relationship. And I think that's key to care management as well. It's bringing in that social aspect. We put in one of our life enrichment specialists who did things like take her to visit her husband's grave, who really just provided that support when she was starting to have a breakdown so that she didn't fall so far during that breakdown. It's been a real success story, and we now seem to be approaching the end of her life as well. So it's a sad but sweet kind of tie-up.
Man, that is a great case, and it's also great to remind all of us that aging life care practices come in all shapes and sizes. And I know they're not shapes and sizes, but nonprofit, for-profit. I know in Northern Virginia, there's one that's tied in with the government program. So that's good to know. And it's also, folks, that what you see here is 3 different personalities. Granted, they're in 3 different regions, but it's also a good idea to talk to a couple of different practices and figure out, where personalities and fit in as well. Okay, we got a ton of questions, so I'm going to start rattling these off. One of the first ones that came in asked how many aging life care managers are in the nation, and I did a quick search, and it said that there's approximately 2,000 members of the Aging Life Care Manager Association. Does that sound right, y'all?
Yeah, that's a good question.
I would
Okay.
say there's between around 2,500, I believe.
Oh, wow, that's great. Okay, and then let's see here. Patricia had a question for you, Allison, is that how was your case brought to your attention? I mean, it's a crisis case. Who referred you and how did that all happen?
Right. Well, this wasn't even an isolated incident. We have other ones like this, but the cousin found us. We helped another family member that like they worked with.
And for our other panel members, how do cases find their way to your organization? So what are some examples?
I think the ALCA directory helps people. That's a great tool for a lot of the public to look at. I think word of mouth. I think a lot of us, like you said, we have 2,000 or whatever, but we need more care managers and we need younger people coming in. So a lot of us, if we've been in the field 25, 30 years, we have a lot of connections. So I think the referrals are endless. You know, it could be attorneys, financial advisors, old coworkers, colleagues,
Yeah.
clients, of
Family
course.
members.
Yeah, yeah.
Let's see. I know that based on your cases, you work with a variety of different providers. Alex is asking, what are you looking for from a local pharmacy to support your clients? That's a great question,
I
Alex.
love it.
Yeah.
I would like to see medication reviews, but also including OTC medications that people are taking that they think are going to cure and help things, but they can also have adverse side effects or maybe interact with something. So I would love them to look at prescribed meds as well as over the counter and a review, like a quarterly review with the client.
We really like the pharmacies that are able to package and deliver the medications as well, and making that as easy as possible. I know it's not necessarily easy, but as easy as possible. It just is a little bit more of, again, back to that relationship when you know the provider, the pharmacist, and they can help speak with that and the communication between the doctor and the care manager and the client.
Mm-hmm.
On the topic of pharmacy, we had a discussion not too long ago. I'm going to find it and drop it into chat on it's a deep prescribing pharmacist. It's a practice of pharmacist that actually works on getting people off of medications when necessary. I imagine when clients come to you all that oftentimes there's just so many medications. Is that something that you often find is creating additional complications for your clients?
Of course, I mean, sometimes clients are on 30 plus medications, but pharmacogenetics is a big thing now where we're seeing pharmacists doing some DNA testing to see which medications are best for certain clients. And that has really helped, especially with some, psychiatric medications or mood stabilizers to find out which ones are the best for them. Also for hypertension and cardiac meds has been huge. So that's been a good find with the pharmacogenetics area.
Great.
And I think to go with that, I just want to say a lot of times we see people going on hospice, right? So much sooner now. It's not really about dying. It's about living and wanting dignity and a palliative approach. So they're on it for a long time. They go on it. They get rid of so many meds and all of a sudden they're doing better. So it is great when we look at the medications and are these really necessary? Are they still effective?
Great. And I found those two discussions that we had on pharmacogenetics and deprescribing, drop those in there for folks that might be interested. Let's see. Somebody made Diane made a comment that she lives in a life plan community or CCRC, and one of her friends there has an aging life care manager. So living in a community, having an aging life care manager, and she says that she calls her rent-a-daughter. But I think a lot of times folks might think that aging life care managers, okay, you're going to help me find a life plan community or assisted living, and then I don't have a relationship. Uh, tell me a little bit about how that might work if you help somebody make a move and then you're working with them in the community.
I think so much of it, I mean, the case that I presented has moved to two different types of communities, as I've mentioned. And, a lot of it, one was independent and then the other one is assisted. A lot of it is making sure, is helping kind of bridge that communication with the assisted living community, being the individual who's boots on the ground, visiting on a regular basis, but not just visiting, allowing the family to be family, and maybe their visits are really about visits, and then it's touching base with the care manager to say, well, how's this going? Making sure that those care plans are done. If there are changes, sometimes even advocating. For example, we have a client in a community right now who has gone on hospice, and she's lived at that community almost since she's opened. So advocating to say, she's spent down, is there any way that you can garner a deal with her and her family? It's not that people don't want to pay something, but can we honor what has been given? So all those little things.
Okay, let's see. Vicky has a question here, and this is a good one. And I realize, we're Vicky, we don't have a magic wand, but let's address Vicky's question here, which says, what does someone in Western North Carolina do with a relative with severe Parkinson's disease, but not eligible for local nursing facilities? He's only 60 years old. These facilities won't take anybody under 65. Any words of wisdom for Vicky?
I think that she could start with the local Office on Aging and Independence in her area. There's also ALCA care managers in that area. You shared that website. She could put in the zip code. But if finances are an issue, you definitely want to start with the Howard County office. Here, we do place people younger than that age in skilled nursing facilities. There's also small residential, but we realize you'd have to tap into, resources if finances are limited.
And sometimes, every state is a little bit different. So all the entitlements are different in different states. But if he is disabled, then sometimes he can be eligible for a waiver program, which helps bring people into the home to help care for him. So it's all dependent on what the state has and what he's eligible for.
Right. And one of the great things about the district actually is they've opened up 4 assisted living communities that accept the elderly person and disabled waiver, EPD waiver, which is fabulous. Most of the time, I know from our experience in Maryland, it's the smaller residential communities who will accept that, and they're usually full. These are starting to get a wait list as well, but it's a great resource to have because it does mean that somebody's there 24/7 to be available. I know that's one of the not misinformation, but misunderstandings that people have. They believe that the waiver is going to be 24 hours, and in the DMV anyways, it's not. So plus there's a wait for that.
And then also, Vicky, like another great resource is local Parkinson's organizations, foundations, support groups, especially support groups. When you're at a support group, it's sort of like, oh, I went through that with my mom, this place over here doesn't, takes younger residents, what have you. So hopefully area agencies on aging, aging life care managers, some support groups, you can find some resources, but this is tough. These are tough questions. Let's see. I'm surprised it took somebody this long to ask this question, but we actually had a few I see here. But Rita says cost basis. How do you all charge for this? By the hour, by days, ballpark costs? Any sort of feedback on that?
I'm happy to take that one. I mean, I think a lot of us work together. We refer to each other. We get together at chapter meetings. I think that a lot of us do charge differently, and especially if we're like a small practice or we're a very large practice. Some take retainers, some do a package plan, some do hourly. So, and because we are so busy, a lot of us are not able to keep up with the demand. We can meet with someone, I can, in an hour or two and kind of knock it out of the park at an hourly rate. It does not have to be a lot of money. And we can be ongoing, or we can put a plan of care in place quickly and be done and on call when you need us. I mean, that's how I like to represent people. I don't know what you guys want to say.
I think every case is a little bit different. Some people need more support, and during crisis, obviously it's a little, the number of hours go up, and then as everything levels up, then sometimes you don't have to see us, for a while, and you just call us when needed. But it's good to have us in your back pocket in case an emergency does arise, and then we already have all the information already, so we can jump into action.
Yeah.
Great feedback, y'all. Okay, and I see that we've got a few questions about contact information for our panel members. I'm dropping everybody's email into chat there. That's probably a great way if you want to follow up with anybody, including Tiffany, who's on. Okay, where are we at here? Okay, Nicole asks, how do you differentiate yourselves from certified seniors advisors, as they are generally not degreed professionals in the space specialty to get certain certifications? And there's other, acronyms and alphabet behind people's names: CSA, Certified Senior Advisor, Dementia Professional. And I think somebody had actually asked, how do you become a care manager? So maybe we can kind of mix all that up in a response.
Anybody want to take this, or do you want me to take it? I'll take it.
You start, Rebecca.
All right. So I would say all of the care managers are licensed professionals. So as I said earlier, most of us are nurses, social workers, occupational therapists. So we have all been in the social services field for a while before becoming a care manager. To become a certified aging life care manager, you have to practice as a care manager for a certain amount of time before you can sit down and take the NACM test, which is the National Association of Certified Care Managers test. And once you take that test, then you become an advanced professional. So there are levels of care managers, but that is how one becomes a care manager. For this other certifications, I can't speak on all of them, but some of them you don't need any certification. For a certified dementia practitioner, a lot of caregivers can become certified, dementia practitioners. So those are, they don't have standards. We have a board of ethics. We have standards that we have to adhere by according to ALCA, because that is how we get our certification and how we present ourselves as a united front.
Great. Okay, and I dropped in the NACM website there, and we got that there. Okay, let's see. So somebody asks, so does care manager make sure levels of care, management of care, and people are in place? For example, powers of attorneys, or does it depend on who does a care manager make sure levels of care and management of care, and the people are in place. For example, powers of attorney. So I imagine those are some of the first questions that you all work with on their clients.
That's page 1 on our 5-page assessment.
Yeah, and I think a lot of that, it is done during our assessment, is to understand exactly what the client has in place. And as Allyson said, that's usually one of the first questions we ask. And then it's a referral over to an elder law attorney to help get that set up. And frequently what we'll have in the care plan, if you don't have a power of attorney, is maybe discussing who would be a good power of attorney for you. Do you have a family member, or will you need to pay someone? I know I saw a question asking if care managers ever become powers of attorney. They do. It really depends upon the practice. At Seabury, we do not. But I know, for example, we had someone come down from Pennsylvania where they had, who then worked for us for a few years, who they had one side that acted as powers of attorney, but that power of attorney was never the care manager. And that was on the opposite side. So just so there's no conflict of interest. We do, though, work closely with a guardian or a power of attorney if one is in place. And again, I should say for all of us, the older adult is the client. We're receiver for most of us. The older adult is the client, but we recognize we're also taking care of the caregiver. And it's often client choice. So, for example, I can talk until I'm blue in the face about putting a power of attorney in place, but then I just support them until they're ready. So that support might look like, okay, what things are we going to put in place in case something happens before that? So.
And Christine, I'm glad you brought this up, because where I'm often recommending aging life care is when I get that phone call and it's sort of like, my sister thinks mom should live in the basement. I want to get her into an assisted living. And my brother said, don't spend a penny because mom's money is my retirement. Like, oftentimes when a group of siblings come together and bring on an aging life care manager, they think they're the client. But you just reiterated, even if they're paying the bill, it's mom is the client. That's who the decisions are made for.
Right. And again, if mom can't make her own decisions, we're obviously taking that into account. By the same token, I would say there are still questions to be asked. And even if somebody has, is well into dementia, being able to understand what their feelings are, looking for those cues as to, are they actually happy here? So we're still getting information from the client, even when they're not the decision maker. But yes, even if somebody else is paying, we acknowledge that, we recognize that. Sometimes it's a fine line, but the client should still be the client, the older adult.
Okay, we got a pile of.
It's about talking, having family meetings and getting everyone kind of able to speak about what they want for mom and try to get them on the same page. But it is about kind of diffusing different situations sometimes within the families to make sure that the client gets the best care.
It can be a lot of mediation, and a lot of it is education and coaching on being present where mom is today, not a year ago, and not where I want my mom to be, but where is she right now and what would be the best decision. One real quick thing on advanced directives, and I'm sure the other ladies are finding too, people say, I have it. I met with this attorney. I have an $8,000 beautiful binder here, and then you look at it and the wife is appointed as the primary healthcare agent. You're there doing your assessment, which includes, we know so much, she should not be the one called when the caregiver goes to the hospital. So that immediately needs to be changed, a primary moved. Also looking through the wishes, which takes a lot of us probably 10 seconds. So when we do the most and they say, I don't want a feeding tube. And then if they're in a persistent vegetative state, they said, no, I don't want it. But if I'm in an end stage condition, I do want it. So it's a lot of education, and I encourage clients to read them annually. And of course, any significant change in a health condition.
Man, yeah, this just speaks to why we all it's good for us all to have an advocate and somebody else that you
Yeah.
can trust looking at this. Okay, we got a pile of questions. It's about 10 minutes to the top of the hour. Let's try to get through a few of these. Can you all hang on a little bit longer if we
Yeah.
don't get through them? Okay. This is a really good one. What is the Christine talked about this client working with them for 11 years, but somebody is curious about what's the longest relationship that you've had in your practices. And then they were also curious if you know if any care managers have served as the like a personal representative or a power of attorney for somebody.
I would say the longest client that we have had, we've been around for 24 years. Our longest client has been with us for 23 years. He
Whoa.
is a special needs client. So he wasn't, he's still aging, but that is our longest client. And my company does act as healthcare power of attorney for some of our clients.
Okay.
Mine is 8 years. We also act as healthcare POA. I think the question just said POA, though. Most of us do not do financial. We can't, we don't want to. I think it's ethical, conflict. So usually attorney or a money manager kind of deals with that stuff, and we do the personal representation.
Okay, great.
And I think ours is 20 plus years as well, although that group is dwindling. And we do not act as power of attorneys.
Okay, great. Okay, and then here's a question from when Allyson was talking, and you talked about 70% of people wanted to pass away and die at home. They felt that was an eye-opening piece of information. So
Yeah.
did you say this is because we need to do more planning in crisis situations?
We need to do more planning before the crisis. So, right, we all know, the graying of America, that older adults by 2035, which isn't that far away, is going to outnumber people under the age of 18. That we're saying Alzheimer's is going to triple by 2050. For me, we are in an epidemic, this country, and we are not prepared at all. And I really love the Conversation Project. You can Google it. I did a local podcast about it, and just having conversations and talking. And Death Over Dinner, Steve, I think you had that guy from the TED Talks, which was so cool. So I think if we could just talk and share with our loved ones and get affairs in order, you can pay a lot of money, or you can use the Attorney General's advance directive and do it for free. Yes, pre-plan, or you will not meet your goal.
Mm-hmm.
And it's sad. I think for me, it's very sad what I saw in the nursing homes for decades.
Mm-hmm.
I don't want to see
and
that.
we all know that we all know that these conversations are hard, but we all want to make sure that our loved ones pass the way they want to, right? I mean, it's a transition. We're all going to have that transition at some point. We want to make sure that we know what our family members want and our loved ones want. And we also I want people to know what I want when that happens to me.
And what we don't want, right?
what
At
we don't want.
53, I did the Death Over Dinner. I have a 23 and 19-year-old. And guess what? They are aware if they get the call.
Yeah. The Death Over Dinner, and I'm gonna type that website in, is so I hate to describe it this way, but I would say it is so much fun. I don't care how well you know your loved ones. If you do a Death Over Dinner, you will get to know them better, and everybody will usually say, I was kind of nervous coming to this, but I'm really glad that I did. It's a very cool concept. Okay. Let's see. Rita says, would $100 an hour or $200 an hour be a ballpark, higher or lower? And again, every practice is a little bit different.
I would say in the Mid-Atlantic, I'm the president of the Aging Life Care Mid-Atlantic, and I would say in the Mid-Atlantic, It ranges anywhere from 150 probably to 250 an hour. And most people break that up into 15-minute increments. So if there's just a phone calls, we're making appointments, it's 15 minutes, but we do, that is the hourly rate generally in that range.
Yeah, and then obviously, like, there are sliding scale programs like Christine has that you might look around for. Actually, a question came in. I don't know who asked it because my screen is all going crazy, but it's somebody who's asking about insurance paying for aging life care. There's health insurance and long-term care insurance. Do either or both pay for aging life care services?
Health insurance does not, just like it doesn't pay for custodial care or assisted living. Long-term care insurance does often, and many of us do, write the invoice correctly for the client and they get reimbursed.
But only for a certain amount generally.
Yeah. Just like they have the certain amount for everything, right? But yeah, if they're lucky to have the long-term care insurance, they can use that.
Great. Okay. Oh, and Allyson, like another follow-up question to your case, the individual you spoke about, what an amazing and informative story. Are you willing to share and talk about how you were paid for this example? Because it sounded like, was there like an appointment or a guardian?
The cousin, yeah, once they got appointed guardian, the family was a person, the attorney was a property. We took a risk, and there are times we don't get paid. So I'm doing better collecting up front. But yes, we did get reimbursed at an hourly rate, and then we were just done. Yeah.
Okay, great. And let's do a few more and then we'll call it quits here. This has been a great discussion today. Let's see, Christine, can you speak more about the equity something? You talked about something related to equity and they just wanted you to restate that.
Sure. Yeah, it's the pool of money that we have in our budget to provide the subsidized care. We call it the equity fund. And that's, when we do our fundraising and other things, when people make a donation to us, that's where we put it for our program, just to reduce the cost of care management. So if, our hourly rate is 180, so that would reduce it down for folks.
And then Kristen says, it's my understanding that long-term care insurance will only cover chronic conditions. So what if you're in good health now? I think the point of long-term care insurance is cover. I don't think there's much coverage if we're in good health. But do you guys all want to talk?
Well, that's for, for the long-term care to kick in, right? You need the assistance with 2 ADLs or the neurocog impairment, but they can come to my office and meet with me for advanced care planning and discussions, and it's covered.
Oh, wow. Okay.
So if we do a home assessment and we talk about what it would look like, what's it going to cost when someone needs care, it's covered. So GCMs can be covered, based on the policy.
Okay, great. All right. Well, it's 1 o'clock. I think we got through most of the questions. This has been a great way to kick off this monthly series. Man, we covered everything here, y'all. And I'm gonna I got the recording. I'll put it up with all of the chat, all those notes, contact information for everybody, links to the Mid-Atlantic and the national chapter website so you can easily find aging life care managers. I want to thank you all and thank all of our attendees for the great questions and engagement.
Yeah, we love it.
All right.
Thank you so much for having us. It's wonderful.
Yes, it's been great. Thank you.
Okay, we'll see you all at the next one. Thanks a lot.